I'm going to talk a little bit about collaboration. So remembering yesterday's talk about conflict versus collaboration, I'm going to typify what happens when you collaborate and how impactful it is on the practice, your practice of medicine, and engage all of you in consideration of registries. So I'll show you two examples that are in the milieu of your practice environments. And so if you wish to engage in them, it's hugely helpful. So the talk is on augmentation of fragility fractures. And these are osteoporotic fractures of the spine, thoracic, lumbar, and pelvis sacrum. Let's see if what we know in the impending and immediate future is there's going to be a tsunami of individuals who are coming and are going to crash as an osteoporosis wave in this generation and the following generation. And we know that's true because in this generation at this time, there's a 93 to 97% neglect rate, meaning that women with this diagnosis are neglected. They are not given appropriate medication, they are not given diagnostic measures, and their disease is not arrested or reversed. The most recent publication on this is a Pearl Diver data publication in the journal Arthroplasty, which is orthopedic joint replacement journal. And they looked at a Humana, which is a Medicare Advantage program, and they found more than 30,000 patients with a history of fragility fracture prior to their virgin knee replacement. Virgin being it's a first joint replacement of their knee that they had. They excluded all other people from this group. And their second cohort was a matched cohort of 25 to 30,000 patients. So it's a huge number. And the only difference was those patients did not have a history of a fragility fracture in the previous 5 years before they got their knee replacement. And the differences in outcomes are staggering. These women, mostly, have devastating consequences directly related to the fragility of their bones. So the components that were put in would loosen. The operation would get infected. If you had loosened components or you broke your bone around the knee replacement, had to go back to the operating room, you had a 214% increase in infection. So it's the presence of the fragility fracture, not the common diagnosis of DEXA scan osteoporosis. The presence of the fragility fracture, a clinical diagnosis, indicates the profound vulnerability of the population. And 3% of that population with broken bones before their knee replacement, 3%. Were treated with osteoporosis medication. That means a 97% failure rate for the diagnosis of a ground level fall with a broken wrist, broken spine, broken hip, broken shoulder, the common osteoporosis fall related fractures. So this tsunami is going to arrive, and it's really incumbent on all of us to have an awareness that when you're treating fragility fractures, the treatment that you provide is profoundly beneficial. So when you look at the pain relief scores and the function scores in the registries that I'm going to show you, they are hugely impactful. And the healthcare utilization savings is hugely impactful for Medicare. So it's in our interest to enroll in these registries and to engage in managing the disease. There are a lot of data and many studies on what are the negative impacts of osteoporosis. And they are devastating impacts, not only on your longevity, but the quality of your life. And as one of the articles summarized, osteoporosis fragility fractures is a spiral of debilitation, a loss of function, destitution, and death. Those are the three things that happen from osteoporosis, and they happen across an entire population of vulnerable people. Because remember, women outlive men by 7 years. So these women are dying alone with a horribly painful fracture that is entirely treatable and preventable. And we're failing at a 97% rate. Food for thought. So what are registries? Registries are a population study methodology that is different from the randomized control trial. And the best way to think of the randomized control trial is to think of a portrait photograph in a portrait studio that you would go for a family picture or a wedding picture. It has incredible clarity. It has one topic, one focus, one entity that and it doesn't allow for any change of circumstance. So if it's a family picture, it's a family picture, and you're just, how do you assemble the kids? If it's a wedding photograph, there's just two people in it. And as soon as they take their wedding clothes off, the photographic studio is done. They've got their photograph, but you cannot change the circumstances in a randomized control trial. It is strictly constrained in order to produce the validity that it is seeking. It does not reflect the real world, where none of those constraints apply. Whereas the registry is very much like a GoPro camera. It's taken in real time. It sees all of the movement in any environment in which it's traveling, whether it's underwater seeing the fish and the current and the tide, or it's looking up into the atmosphere to see the weather or the time of day. And anything that changes gets captured by the registry because it's real time, real world. So what you find out is much greater depth of knowledge, much greater valuable information that is not constrained. So registries are a very important reflection of your practice. Randomized controlled trials are very important reflections of strictly constrained circumstances in certain diagnoses in your practice. Each of them have their value. Each of them are different from the other. So when you're looking at the reason why you're doing registry work and the reason why it's blooming so much in the United States is it's real-world information. And real-world information allows you to make budget decisions if you're a policymaker. It allows you to make device and innovation decisions if you're an inventor or a product manufacturer. And for insurance companies like Medicare, it gives huge information around what happens to the population and the cost of doing that care, and how long does that benefit last. And that is the value-based equation. The benefit of what you do over the cost of what and how long it lasts. So in participating in registries, you're participating in value-based healthcare. You're participating in population-based medicine. So when we look at the Vertebral Augmentation Registry, what you see is it's the largest registry in the world. It's 2+ times greater than the Swiss registry. And it was hugely impactful in informing Medicare, the Medicare Administrative Contractor meetings, the MACs that were spoken of yesterday and today. This was hugely influential data. They actually came to us in 2014 and said, you know, we saw these two articles in the New England Journal that were articles that reflected no one's practice and were subsequently discredited, but they had huge street cred because they were blinded, as if you practice medicine, blinded sham trials. And they asked us, is that information accurate? Is it real? And we said, well, the registry will tell us what the real truth of the real world experience is. And it refuted those articles and dispensed with them as accurate reflections of the practice of medicine. And they were subsequently degraded and for most of us discarded. But what you saw, the real world, is that there are 735 patients in this registry. The incidence of cement leak is frequently happening in a minority of patients, 1 out of 4, roughly. But if you look at the neurologic consequence or the complications associated with, there are none. There's adverse events are less than 1%. There are no neurologic complications, which is the concern you have from cement leaking out to adjacent neurologic structures, and there were 0. And remember, this isn't done by an academician or an academic center, a center of excellence. This is done by people all across the United States. It's done by orthopedic surgeons and neurosurgeons and interventional pain and interventional radiology and PM&R, and all of these different trainings result in very little complications. So remember the SAFE? There's your safety right there. And it identified appropriateness. MR positive, fracture, pain severity in the patient at 7 or out of 10 or greater, and a functional disability score, the Roland Morris questionnaire. And so it's safe. And this is the slide that changed Medicare's policy nationally. So there's a lot on this slide, but let's just go over it simply and easily. If someone gets treated on the day that the fracture occurs, they come right in, they satisfy the registry criteria, it's painful, it's altering function. So they're taken to the fluoro suite immediately, and they receive vertebral augmentation. What you notice is they are profoundly disabled. So Roland Morris goes to 24. And 22 to 24 is bedridden, hospice, terminal, and they are at 20. So they're basically housebound and profoundly disabled. Their pain score is 8 out of 10. So they are not sleeping, cough, sneeze, get dressed, stand up, walk, do anything. It's devastatingly painful. And as soon as you treat them, pain goes away. So 1 out of 10, you're dancing on the cabaret tables because your vertebroplasty works so well. And that benefit is sustained. So there's no deterioration. So now you've shown quality and efficacy in your registry database. Now imagine that you have a payer that delays authorization and restricts access, which are methodologies of local coverage determinations, LCDs, and you'll hear a lot about LCDs as you get into practice. So we showed that these are all Noridian data. So all of these are Medicare patients west of the Mississippi. If you wait 6 months, they are still profoundly disabled. They are still profoundly painful. So this disease and this entity does not disappear on its own in patients with vertebral compression fractures. Some patients are lucky and their pain relief is spontaneous and it occurs within about 6 weeks. Many of these patients are profoundly disabled. If you operate on them 6 months later, you still get an MCID change, minimal clinically important difference of 2 to 3-fold. So the operation still works. You've tripled the cost. That is all you have done. So the MACs looked at this, and it was obvious to them that this is their data. It's just that, they happen to be a Medicare administrative contractor in Virginia or Texas or Connecticut, but what the MAC sees in the West is the same. So they knew this is their data and these are their costs. And if they participate in any form of delay, they are running up their own costs and they're not benefiting anyone. And that's the data. That's the data that changed their behavior, the money, not the outcomes, the money. When you look at the data itself, it's profoundly beneficial, and that's why you should participate not only in doing cement augmentation, but you should participate in registry. So what you see is this is pain improvement. Remember, they averaged around 8, and they ended up around 1. And there are very few people age 60 and older who have no pain at all anywhere. So this is a hugely impactful improvement of a very painful condition. And the functional improvement is threefold. The minimally clinically important difference is 5, and they went from 20 down to 5. So that's a 3 to 5-fold improvement for some of these patients. That's a hugely beneficial procedure. The registry is done and run by a data vendor company that has experience in registries across the United States and is working on building registries internationally. The Sacroplasty registry can be thought of as the sacrum is a large vertebral body at the base of the axial spine, and it behaves identically. The techniques in order to accomplish it are different. So, and the frequency of this fracture is less because of the stable nature of the pelvis, but sacral insufficiency fractures are profoundly disabling. So managing them successfully is hugely beneficial for the patient. And when you look at the data on it, it's, again, a threefold minimally clinically important difference in both pain and function improvement. So to conclude this, I'm going to mention some registry principles that are important if you decide to get into registry, and you should. The important things are actually really simple things that might be intuitively obvious to you, but first and foremost, you must own your own data. If you do not own your own data, it will be manipulated and reported by whoever is owning it to their self-interest. And that is something you can only prevent if you own it. You have to supervise yourself about how you report your self-interest. And in registries, there are 5 Ps. The first is the patient. The second is the physician. Physician is not first. Patient is first. Then there's the physician. Then there's either the purchaser, Microsoft, Boeing, Amazon, Walmart, and the payer, Medicare, Regents, Blue Cross Blue Shield. There are product and device manufacturers, and there are pharma. So all of these Ps are stakeholders. In registry work, you represent all of the stakeholders' interests transparently. Because when you do that, all of your stakeholders trust you. And the stakeholders who are talking to each other when you're at home in bed are talking about the merits of what you do, instead of you standing at the podium bragging about the merits of what you do. Those who are your collaborators are singing your praises in your absence, and that's really important. That was that conflict and collaboration discussion yesterday. It's really important to collaborate that way. And then lastly, you transparently report, and you do it frequently. In original registry work, we were doing it every quarter, and we were reporting to all the stakeholders every quarter. Nowadays, you can do it in dashboard form. Back then, it was more manual, but it's the same. You transparently report, because that also builds trust. A very important thing that isn't intuitive, because many of us are type A personalities, doctors must not touch the data. And realistically, humans must not touch the data. If you can do this all with automation and digital technologies, the validity of your data skyrockets, and the completeness of your data skyrockets, and the power skyrockets. If humans touch the data, it degrades. So doctors don't touch data. And then, importantly, 3 questions. Stay on a data diet. Keep it, and Ramo was talking about this when he was going over all of the different data collection tools, Promise this and SF12 that and 36 and EQ5D and blah, 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 blah. The patients tire of that. So you want a score that has a predictive capability. You want a score that has functional data on it. You'd like to have a score that has a quality of life and cost. So the EQ5D, Promise 10, will ultimately supplant ODI. The pain score is always relevant, and you don't need to do it in a visual analog scale. You can do it at a numeric rating, and they're both comparable. So you make sure that your tools are simple, short, but impactful. Because when you have simple, short, impactful data at 100% completeness, you have you're in the sweet spot of what you're trying to accomplish. And lastly, if you look at how registries work, they actually give you the grist of the mill for randomized controlled trials. So the proper way to do things is do your registry first, and out of 50 or 75,000 patients, you'll have 5,000 that have complete data on answering whether osteoporosis medicine this type compared to osteoporosis medicine that type is impactful on any question you want to ask, a secondary fracture or rehospitalization, reoperation, because you already know, hey, we got 5,000 in each group. There's your randomized control trial. So you start with registry. That's the first thing you should engage in. And then you look at, well, what questions can this data answer for me? Because I got a lot of data at high levels of completeness. So it's a very valuable research tool if that's what you want to do. Good, good. Any questions? Perfect. The postprandial snooze has kicked in. I love it. Going after lunch is perfect. All right. Thank you.